All right. So before we get started with today's AMSSM ultrasound case series presentation, just wanted to give a quick reminder about the AMSSM Library of Sports Ultrasound Pathology. This is a great opportunity to take ultrasound pathology you see in the clinic, training room, or sideline and turn it into a peer-reviewed publication to add to your CV. For this, we're both looking for common and atypical pathologies. So definitely encourage any residents, fellows, or attendings to add to this growing collection of cases. And so you can use this QR code to go to the submission and information for this. And then there's also two emails at the top that you can email if you're interested in submitting a case. Otherwise, I have the pleasure of introducing Dr. Patrick Davis today for the AMSSM ultrasound case series presentation. He's originally from Pittsburgh, Pennsylvania, and completed his undergraduate education at the University of Rochester in Rochester, New York, where he received his degree in neuroscience. He then received his medical degree from the University of South Florida and currently is completing his PM&R residency and sports medicine fellowship at the Mayo Clinic in Rochester, Minnesota. And he currently is also serving as the AMSSM Education Subcommittee Fellows Associate Chair. And he's going to be giving us a presentation today on an extensor retinaculum tear.
All right, great. Well, thank you for the introduction again. Today I'm going to be talking about a case of anterior ankle pain in a high school basketball player. So as far as our learning objectives for today, we're going to review the protocol for a diagnostic ultrasound evaluation of the anterior ankle. We're going to review relevant anterior ankle anatomy, identify pertinent ultrasonographic anatomy and pathology, and then we're also going to review the anterior ankle diagnostic report. So to start off with a case, this is an 18-year-old male basketball athlete who presented to our clinic 12 days after a right interlateral inversion injury. Inversion injury resulting in interlateral ankle pain. This occurred while he was stepping on a teammate's foot while simultaneously jumping. And at the moment of injury, associated symptoms included swelling and ecchymosis over the anterior lower leg and lateral ankle. He returned to practice with a lace-up ankle brace several days after injury, but had continued difficulty with running and jumping, which prompted him to seek further evaluation. As far as the physical exam is concerned, so on inspection, there definitely was swelling anteriorly and ecchymosis laterally of the ankle, and there was pitting edema around the lateral malleolus. He was pretty tender to palpation throughout the ankle, but particularly over the ATFL, CFL, AITFL, the anterior calcaneus, the peroneal tendons, and the medial and lateral malleolus. His range of motion was somewhat limited in dorsiflexion and plantar flexion, most likely secondary to pain and swelling. And then his strength was also limited in all planes. This was secondary to pain. As far as special testing is concerned, his anterior drawer did reveal some laxity, but with a firm endpoint, and his tibiofibular squeeze and external rotation stress tests were negative. So we did have some initial radiographs that were obtained. So here I have an AP and a lateral, and a mortise view was also obtained, but really no findings of note. So no fractures or osseous abnormalities noted on these radiographs. So to review the anterior ankle anatomy a little bit before we get started, there's a couple of structures that I want to highlight. So within the anterior ankle, when you think of your anterior compartment, there's three primary muscle tendon groups that you're thinking of. Most medially, you'll have your tibialis anterior. You'll then have your extensor hallucis longus as you come lateral and your extensor digitorum longus. In some patients as well, you'll see a peroneus tertius tendon in that anterior compartment. However, this patient didn't have one. Now, supporting these muscle tendon units within the anterior ankle, there are two retinaculi that help to support these structures. So the superior retinaculum inserts onto the anterior margin of the lateral malleolus and the anterior tibial crest of medial malleolus. The inferior retinaculum is actually two different bands, a superior medial oblique band and an inferomedial oblique band. The lateral insertion of this inferior malleolus is on the calcaneus, and that's called the frondiform ligament, and two other slips insert onto the medial malleolus. So at the level of the inferior retinaculum, all of the extensor tendons have their own individual tendon sheaths. Other things of note within the anterior ankle that will become pertinent to our scan is the deep perineal nerve running through the anterior compartment, as well as the anterior tibial artery, which then becomes the dorsalis pedis artery. Now, as you can see, there's a pretty tight relationship between these retinaculae, lateral structures, superior retinaculum, lateral structures. So the lateral ankle can become pertinent with any of these inversion injuries, obviously, or certainly if you have concern about injury to either of these retinaculum. So as far as our protocol is concerned, required structures for the anterior ankle protocol include the anterior leg compartment muscles and tendons, the three of which I had just mentioned, the tibialis anterior, extensor hallucis longus, and extensor digitorum longus. This would include the peroneus tertius as well, if your patient does have one. The anterior tibiotalar joint needs to be evaluated. The anterior tibial artery / dorsalis pedis artery, deep perineal nerve, and the anterior inferior tibiofibular ligament. And with your AITFL, certainly if you have concern for any pathology in this area, dynamic evaluation is recommended with external rotation in order to assess, and we'll talk about that a little bit later. Optional structures that can be included with this scan as well include the dorsotalonavicular ligament, which we'll touch on a bit later in this lecture, the superior and inferior extensor retinaculum, which I previously explained. Dynamic evaluation can be done of these as well, and we'll kind of talk about that. And then also the syndesmosis. Certainly, if you're concerned with an AITFL injury, you need to be concerned about tearing of that syndesmosis between the tibia and the fibula going more proximally. Now, for this patient in particular, as I had mentioned initially, he did have an inversion type injury, so you want to have some degree of suspicion for your lateral ankle structures as well. So with this patient, we also evaluated the perineal tendons with the superior perineal retinaculum, the ATFL with dynamic testing as indicated, the CFL with dynamic testing as indicated, and the anterior process of the calcaneus and the bifurcate ligament. Now, for some technical considerations before we go into the images, for patient positioning, typically you'll want your patient supine with the knee flexed and foot flat on the table, as you can see in this picture over on the right. For transducer selection, a linear mid-frequency or linear high-frequency transducer should be adequate to get you all of the views that you need with appropriate resolution. Dynamic scanning is incredibly important and can benefit you in revealing structures as you stress them, increase laxity or tissue movement indicating injury. And also we have two of most things, so comparison from side to side can offer you a great internal control when you're evaluating a patient. So I personally like to have a home base when thinking of any scan, a good place to start that you can then find the structures of interest from there. For the home base, I typically think of the talar dome as that base. And here you'll see that you have a thick strip of that hyaline cartilage over top that's anechoic. This is just a good area to kind of get a general view of those extensor tendons. So most medially, we'll have the tibialis anterior tendon. We'll then have the extensor hallucis longus and eventually the extensor digitorum longus. So this is kind of the jumping off point seen in a transverse view for us to better evaluate the remainder of the structures within the anterior ankle. So first, looking at the joint space itself. So this is viewing the anterior tibio-talar joint. Proximal is to the left, distal to the right. So this is a still image in long axis. Here you'll see that as you come down, you have your tibia. Over on the right, this is your talus. And if you're ever confused about where you're at, that thick strip of cartilage, if present, is a good kind of landmark to tell you that you are looking at the talus. Over top, we have our tibialis anterior tendon here. Now we'll evaluate each of the muscle tendon units of the anterior ankle in a little bit more detail. Now, for these upcoming images, we have mostly kind of short axis sweeps looking through them. Certainly, if you were curious about any pathology, you would want to get a long axis to better evaluate as well. So the tibialis anterior is the largest and most medial of the extensor tendons, roughly twice the size of the EHL. Just another kind of tool in your toolbox if you're having difficulty discerning between these two tendons. It travels from the anterior compartment to insert on both the medial cuneiform and the base of the first metatarsal. So here on the image on the left, we see a short axis evaluating the tendon, sweeping down and ultimately going to its insertion at the base of the first metatarsal. Now, you'll note within this, my laser pointer off here, within this sweep, you'll see that that tendon does become somewhat hypoechoic as going down, and more care should be taken to kind of tilt and wag and to keep that tendon hyperechoic as you're evaluating it through the anterior ankle. On the right, here, we have a long axis view of that tibialis anterior tendon as well. And working in a sweep, we're working from distal to proximal up to the level of the muscle belly and musculotendinous unit. So for all intents and purposes, that tibialis anterior appeared normal to us, at least on our initial diagnostic scan. Next, moving more towards the lateral portion of the ankle, we'll evaluate the extensor hallucis longus, which lies between the tibialis anterior and the extensor digitorum longus, and inserts onto the dorsal surface of the base of the distal phalanx of the great toe. Here it's evaluated in short axis, as I had mentioned. If you were concerned with pathology, you certainly would want to get good images of it evaluated in a long axis as well. And we follow that extensor hallucis longus tendon as it goes down and inserts onto the distal phalanx of that great toe. Again, paying careful attention to tilting and wagging to keep the tendon hyperechoic and centered in your screen as you sweep through evaluating that tendon. For the last of the tendons available in this patient in that anterior compartment, we're now looking at the extensor digitorum longus. So what you'll notice with this tendon is it's a little bit more flattened in comparison, and also will develop into 4 different slips that reach the distal phalanges of the 2nd through 5th toes. So we see the tendon here developing into those 4 separate slips as we follow those slips down, and ultimately would follow them down to their insertion. I mentioned that there are some nervous and vascular structures that we should be concerned with. So the anterior tibial artery comes down through the anterior compartment of the leg, and it doesn't become the dorsalis pedis at the level of the ankle joint until just inferior to the border of that superior extensor retinaculum. So in this image here, you can see what is the anterior tibial artery. The superior extensor retinaculum is over top. As you sweep more distal, that'll become the dorsalis pedis artery. And allow me to rewind briefly so I can also point out the deep perineal nerve running with that artery. So with our patient's mechanism of injury and certainly having a significant amount of swelling in that anterior compartment, we were concerned initially with an anterior inferior tibiofibular ligament injury, potentially a syndesmosis injury as well, known as high ankle sprain. So the anterior inferior tibiofibular ligament extends in an oblique orientation in an upward direction from the lateral malleolus to the tibia, as you can see over in this image on the left-hand side. It can be somewhat difficult to image and to find correctly. So what I find is a good technique is to start with your image of the ATFL here, and then to use a counterclockwise rotation while anchoring your probe on that lateral malleolus to get yourself into the orientation of the AITFL. Now, despite our initial fears that this athlete had suffered an AITFL injury, here you can see that it appears to be normal in appearance. If injured, you would expect it to be more thickened, hypoechoic, possibly with anechoic defects, and possibly with more gapping on dynamic exam, which we'll talk about here on the next slide. So as we discussed in the beginning, dynamic scanning is an exceptionally useful tool in order to better evaluate the integrity of a certain structure that you're evaluating on ultrasound. So given the intact nature of this AITFL, we have only an examination of the right ankle with no comparison to the left, but certainly if we had noted that there was some pathology, a comparison to the left would be encouraged in order to better evaluate within the internal control of that patient. So here we're offering external rotation as a stress, and you can see that that ligament here is still tensioning. Allow me to rewind. And you see continuity of the fibers spanning from the fibula to the tibia. Now, commenting over here, I have a recent study that came out of a European radiology group in the Netherlands in 2021. They were looking at dynamic external rotation and measuring the tibiofibular distance with external rotation. So using a cutoff of 0.93 millimeters, they found an 82% sensitivity and specificity when doing comparison of this testing to the contralateral side. So something that you can kind of cite and use in order to better discuss the actual predictive value of these measurements. With any concern for AITFL injury, certainly you want to be concerned with the tibiofibular syndesmosis between the fibula and the tibia as well. Injury in this area could potentially show as a defect in the syndesmosis down here. And certainly you could see things such as increased gapping between the fibula and the tibia distance, or potentially muscle herniations through this syndesmosis if injured. So here we have a sweep from distal to proximal, evaluating that syndesmosis with no clear injury. So before discussing the superior extensor retinaculum, I wanted to touch on its kind of anatomic description as well as its function a little bit further. So as I had mentioned previously, it runs from the anterior margin of the lateral malleolus to the anterior tibial crest and the medial malleolus. And what these two retinaculum are their deep fascia that has essentially thickened. And what they function to do is to act as stabilizers of the extensor tendons, but also to facilitate low friction gliding. So if you think it almost analogous to the pulley system in the finger flexors, they prevent bowstringing of the extensor tendons, and they can kind of keep those tendons planted down during dorsiflexion and plantar flexion. Mechanism of injury of the superior extensor retinaculum is typically forced inversion and plantar flexion, which might sound familiar from our initial case presentation, but also forced powerful dorsiflexion can result in injury of this retinaculum. So here on the left, I have, with the arrows highlighted here, a long axis view of the superior extensor retinaculum at the area of injury. You'll notice that it appears thickened and hypoechoic, and there's also some soft tissue swelling lying above this injury. On the right, we have the right ankle, which is the affected ankle, and the left ankle here. So using that internal control of the patient, we're able to compare between the right and the left to further prove to ourselves that this structure actually does look like it has suffered some sort of injury. So on the left here, but it is the right ankle, you'll notice it's that thickened hypoechoic appearance of the superior extensor retinaculum. While on the right-hand side, you'll note that tight fibrillar appearance of a normal appearing superior extensor retinaculum on the left ankle. Something to note as well is you'll see here that the tibia is kind of slightly downshifted compared to the tibia on the left ankle. Ideally, you'd like to have these images as close to exactly the same as possible in order to truly confirm that you're not seeing anisotropy or some kind of small change, but rather seeing an actual difference in the structure that you're visualizing from side to side. This could be due to the soft tissue swelling over top and is certainly just something to note as you're scanning to make sure that you're in the appropriate positioning. Now we bring in a visual of the superior extensor retinaculum. So we're long axis to that tibialis anterior tendon, but now we're short axis to the retinaculum itself. What you'll notice here on the left of the right pathologic ankle is that thickened appearance of the superior extensor retinaculum with hypoechogenicity throughout, whereas over on the left ankle, you'll notice that normal tight appearance of the superior extensor retinaculum. Now, it's important that was more towards the kind of center of the ankle, not necessarily extending out to the actual attachments of the retinaculum. So it's important to assess the attachments as well. This could be, a site of potential additional pathology, and certainly you could suffer an avulsion of this retinaculum, whether it be more laterally on the fibula or on its tibial attachment. So on the left here, you'll see the fibular attachment of the superior retinaculum. So fibula here as the retinaculum attaches, and try as I might to kind of join these images up. These actually aren't contiguous with each other. The pathologic area would be in between, but over on the right here, we do see that tibial attachment of the superior extensor retinaculum with no noted pathology and no noted avulsion fractures. So there's not an explicit paper defining this, but when using ultrasound, there's always the opportunity to use an understanding of anatomy and understanding of kind of the dynamic processes that are underlying in order to better evaluate whether or not there is any kind of discontinuity or injury. So here we have an example of utilizing resting plantar flexion versus dorsiflexion measurements on the right compared to the left to evaluate for bowstringing of the tibialis anterior tendon, potentially implying if there was significant bowstringing that there is in fact a kind of full rupture of that superior extensor retinaculum. One thing to note is if you look at the superior extensor retinaculum for the the pathologic side, it does not appear to be thickened and hypoechoic, as we had previously mentioned in the previous slides. Now, this is because the area to take this measurement was selected in order to better match up the underlying tibia to the undersurface of the tibialis anterior tendon in order to get a more accurate measurement from side to side. So not necessarily the most pathologic site, but a site where this measurement can be most accurately taken. And what we're doing is we're taking the patient from resting plantar flexion into dorsiflexion, measuring the tibia to base of the tibialis anterior distance and comparing from side to side within the patient's own internal control in order to determine whether there is significant bowstringing. So on the left here with resting plantar flexion, you'll see on the affected right side, we had a distance of 3.3 millimeters. And on the left with resting plantar flexion, a little bit more closed off, we'll see 2.8 millimeters. And the difference between these two could be a little bit of soft tissue swelling or potentially another cause, but not really anything of real significance. Having the patient dorsiflex then, the tibialis anterior tendon raises in relation to that tibia base, and you can see the superior extensor retinaculum kind of tensioning over top. And we found equivalent measurements from side to side, so 7.4 millimeters on the right, 7.4 millimeters on the left. No significant bowstringing, so no concern for a significant kind of full thickness superior extensor retinaculum tear that would result in bowstringing. So I mentioned the superior extensor retinaculum. You want to evaluate the inferior extensor retinaculum as well, which can be injured in similar processes. So for the inferior retinaculum, there are two bands, as I had mentioned, the superior-medial oblique band and the inferior-medial oblique band. The lateral insertion is on the calcaneus, and this is known as the frontiform ligament, and the two others slip and insert onto the tibia/medial malleolus. So on the left here, what you'll notice is the frontiform ligament running over top here. So that's going to be the lateral insertion of the inferior extensor retinaculum onto the medial malleolus, or onto the, lateral side. So with that, you have your ligament here, and there's actually three different slips to this frontiform ligament. So this is referred to as the lateral ligament here, the lateral band. There is a intermediate band that runs this way. And then if you were to visualize, you would actually see that there is a medial band as well, but that's difficult to visualize here. And I had mentioned previously that this was attaching onto lateral malleolus. It's actually attaching down into the sinus tarsi, so into the calcaneus, with your talus over here on the right, if you excuse me. Over here on the right-hand side, what I want you to note is that here we have the other insertion of the inferior retinaculum coming over onto the talus. And here you'll see the extensor digitorum longus tendon. So that could be a good landmark if you're looking for these two different essentially slips, that the lateral band goes over top and the intermediate band comes underneath that extensor digitorum longus. The dorsotalonavicular ligament is also important to kind of look at with any of these inversion plantar flexion injuries. It's a thick band extending from the talar neck to the dorsal aspect of the navicular, and it is stabilized medially by the spring ligament. It functions to stabilize the talonavicular joint, and mechanism of injury is typically with plantar flexion inversion. So this is why it's important to discriminate kind of in this injury pattern, making sure that you don't have any concomitant injury of this ligament. Here it has a normal appearance, but you can see more proximally there's some anisotropy, which should be cleaned up in order to get a better full view of that ligament. We had mentioned a lateral ankle sprain mechanism, so you want to be concerned with tearing of your ATFL. So these lateral structures were added due to that mechanism of injury, so we won't spend as much time highlighting them, but I think it is important to kind of go through exactly what we were evaluating here. In this comparison, on the left, you'll see the uninjured ATFL, where on the right, you will see the injured ATFL. The right one appears thickened, hypoechoic, with undersurface fiber tearing, anechoic areas consistent with a high-grade partial thickness tear. Now, the ATFL can also be dynamically evaluated. Here, with our dynamic evaluation, we used internal rotation to evaluate for tearing of that ATFL. In some recent literature that's come out, it's been shown that that's a bit more sensitive than doing your typical anterior drawer exam. So here we have a sweep going through, and despite poor visualization of those remaining fibers that we saw previously, let me switch from my laser pointer here. What you will notice that there is tensioning of the ligament and there's no clear excessive gapping. So that seems to indicate that there are still some contiguous fibers, meaning that the ATFL is not completely ruptured, but does definitely have some high-grade partial thickness tearing. Next, we'll examine our calcaneofibular ligament. So with this patient, it was a little difficult to examine him dynamically, looking from dorsal to plantar flexion for elevation of those perineal tendons, which would indicate continued continuity of the calcaneofibular ligament. However, secondary to pain, it was difficult to get a really good dynamic exam on him. So as we go through this sweep, you'll see the fibers down here, which appear to be intact without significant thickening and change in the typical echo texture. There's some attempt to plantar to dorsiflex to see if we can see elevation of these perineal tendons, but he was experiencing significant pain, which limited that portion of the examination. So if you are evaluating these lateral structures, you have to take care to evaluate your perineal tendons as well. And he certainly did have some tenderness of the perineal tendons on exam. So here we see our perineal tendons sweeping down. And as we come around that lateral malleolus, you will see a small amount of fluid in here. But the remainder of these anechoic areas are the perineal retinaculum, both superior and inferior. On the right, given the inversion mechanism, you also want to make sure to take care to evaluate your peroneus brevis insertion as it comes into the base of the fifth metatarsal, making sure that there's no avulsion injury, which there doesn't appear to be, and also there appears to be good typical appearance of that peroneus brevis tendon. All right, two more structures to hit here. So anterior process of the calcaneus and the bifurcate ligament. Important to assess in a lateral ankle sprain mechanism, as anterior process fractures can also often be misdiagnosed as lateral ankle sprains. And also there can be avulsion of the bifurcate ligament with forced inversion of the ankle and hindfoot. So here we have the anterior process of our calcaneus, and then we have our cuboid over here. Next, we take care to evaluate the bifurcate ligament itself. So it originates off of the anterior process of the calcaneus and has two bands, a more lateral calcaneocuboid band and then a more medial calcaneonavicular band. They function as a key stabilizer of the midtarsal joint. And the appearance here in this image, first you'll see the calcaneocuboid band, which does appear somewhat hypoechoic and thickened, before we switch to the calcaneonavicular band, which is normal in appearance. So concluding our evaluation, so we'll go over our report now. So this was a limited diagnostic scan of the anterior ankle and lateral ankle. Indication was acute anterolateral ankle pain after inversion injury, with the patient positioned supined with plantar foot flat on the exam table. We utilized 214 and 418 linear array transducers, and our findings were as follows. So there was thickening and hypoechogenicity of the superior extensor retinaculum without full disruption. The fibular and tibial attachments were intact without avulsion, with no clear bowstring of the tibialis anterior on the right when compared to the left on our dynamic evaluation. The inferior extensor retinaculum was intact without signs of low-grade injury. There was an intact AITFL and interosseous membrane with no significant diastasis on external rotation stress testing. Thickening of the calcaneocuboid portion of the bifurcate ligament with a normal calcaneonavicular portion. The ATFL did appear thickened and hypoechoic with focal anechoic defects consistent with a high-grade partial thickness tear, but with minimal laxity on dynamic exam. There was a small subtalar joint effusion, normal sonographic appearance of the anterior tibialis, extensor hallucis longus, extensor digitorum longus, perineal tendons, calcaneofibular ligament, and talonavicular ligament, and no tibiotalar effusion. So ultimately, our diagnosis, a partial thickness tear of the right superior extensor retinaculum without evidence of bowstringing, with high-grade partial thickness tears of the ATFL as well. So our final diagnosis is just as I had mentioned, partial thickness tearing of the superior extensor retinaculum with high-grade partial thickness tearing of the ATFL. Overall, he was able to return to full contact practice roughly 1 month after initial injury and has been utilizing a lace-up ankle brace since for the remainder of the season without recurrence. So a couple of take-home points from this case. I think one of the main ones is to beware of the ease of a lateral ankle sprain diagnosis. Certainly, this patient came in with a inversion mechanism of injury, playing basketball, running to that anterior leg or lateral ankle sprain, excuse me, is definitely, what would seem to be the most common thing. However, there were a few things on exam that stood out to us as odd, which prompted further evaluation and particularly prompted doing this diagnostic ultrasound. The amount of swelling and ecchymosis he had initially in the anterior portion of the ankle was definitely concerning, as well as where he was tender to palpation. So because of this, we evaluated the anterior ankle, adding on those lateral ankle structures with what we assumed was kind of a lateral ankle mechanism. Dynamic scanning offers a unique opportunity for evaluation, even if there's no set protocol. Certainly, there's no protocol for the bowstringing exam that I had mentioned previously, but understanding the underlying anatomy and the function of that retinaculum can help you to kind of build a dynamic exam that helps you to better assess those underlying structures and their function. And finally, side-to-side comparison is a powerful tool. Each patient comes with essentially their own internal control for most things. So take care in ensuring that you measure and evaluate at the same level, but this can be an incredibly useful tool in order to better evaluate underlying structures and compare to an internal control. So with that, I am done here for the morning, and we'll open it up to questions and hopefully some answers if there are any.
All right, Pat. Well, thank you so much for that presentation. Obviously, bringing awareness, I think, to an injury that we don't often think of, but probably sees us, more often than we're actually being able to pick it up. But as you had mentioned, I think now with ultrasound, this is a great utility, especially with the resolution of the machines, as well as in the dynamic nature and side-to-side comparison. Probably something that we should be evaluating much more frequently than we're doing, just because, as you had mentioned, kind of the common structures that we're thinking about are going to be those ligaments first, as far as, getting injured. So this is really appreciated to kind of bring more awareness of this type of injury, then obviously a thorough protocol along to go with it. The only thing I was going to kind of reiterate and discuss a little bit more was the information you had for the AITFL. It was very
Yes.
interesting as far as then the measurements. That's something that there hasn't been as much standardization, and so that's where that paper is extremely helpful to kind of give some baseline measurements and just to kind of go off that. Recently, we're looking at that as well too for some of the college football athletes here at Vanderbilt, and we found very similar measurements as far as the baseline of being a side-to-side difference of 1 millimeter. As far as being potentially abnormal and indicating an ITFL, a ITFL tear. So something that you can use, as well as then what we found too was if you're doing dynamic examination, is it looked like actually with eversion stress that space can decrease by around 0.5 millimeters, and then doing the Taylor tilt can actually increase it by around 0.75. So something once again for these ligament injuries, we're just trying to get more standardization and just more awareness of these baseline measurements to kind of figure out what's normal versus abnormal for our patients. And so in having information like this, kind of cutoff values is very helpful. And then one other thing to kind of note for the AITFL is that sometimes you can have an accessory Bissett's ligament. And so for that, usually it will be a little bit inferior. So sometimes if you feel like you're getting to that area first time scanning these a few times and you're seeing what looks like a possible two ligaments, it is that they can have that accessory Bissett's ligament. And sometimes you can actually then even flip into that rather than that long axis view into a transverse view, which we always don't think about looking in ligaments just because they're so compact. But usually when you flip into it in that view, you can actually see very two distinct bands, and then that can give you a good image of that structure. Just to be aware that obviously sometimes that can continue to remain intact. And so that's why you sometimes may have more stability, or obviously that can get torn as well too. So that was going to be the only kind of added information I was going to bring in. Otherwise, I'll see if there's any other comments or questions that people have.
Yeah,
They,
so I think there's a question on how the scan affected
yeah,
the
yeah.
management of our patient. I think that from our standpoint, it didn't make, we kind of treated him, almost as a lateral ankle sprain, as far as getting him back. And obviously, he was able to make it back within a month of initial injury. I think that the kind of take home point is particularly that bowstring exam that we had conducted. Certainly, if he had displayed significant bowstringing and some discontinuity of that superior extensor retinaculum, that would have been a great, kind of indication to us to potentially immobilize him and get one of our surgical colleagues involved. So, something to pay attention to that definitely would have altered our management. But he healed, pretty well with kind of standard, price, protection, rest, ice, and then gradual return to basketball with that lace-up ankle brace.
Yeah, I guess it would be interesting to see just a re return to play for these injuries. Obviously, being able to detect them, are they slightly longer than your just typical lateral, ankle sprains and things like that. So.
Yeah, definitely.
All right. Well, otherwise than that, I don't see any other questions. So thanks again, Pat, for this presentation. And then we'll meet again in 1 month for another fellows presentation in early March.
Fantastic. Yeah, thank you all, and thank you everyone for being here this morning.